everyone, this is Dr. Govind Raigar. In this video, we will discuss about sedative hypnotic drugs. First of all, what do you mean by sedative? Sedative is a drug which will induce drowsiness. Okay? Then what is a hypnotic? This is a drug which induces sleep. Like sedative is a drug which produces drowsiness. The same thing which happens after half an hour of a lecture. Okay? Then hypnotic is a drug which induces sleep. The same thing which happens after 1 hour of a lecture. So same thing is the drug. That means sedative hypnotic is the same drug. If we give in lower doses, it will produce sedation. If we increase the dose, it may produce hypnosis or sleep. Clear? So for understanding this, first we need to know how we can produce the sedation or sleep. What we need to do? We need to depress the brain, obviously. So that means if we depress the brain, we can produce sedation or sleep. That means the drugs are CNS depressants. And for that, we need to know how we can depress the brain and which is the normal neurotransmitter that depresses the brain. What is the inhibitory neurotransmitter in the brain? Yes, it is GABA. So first we need to know about GABA, then we will discuss about these drugs. In the brain, the neurons contain a channel for chloride entry. There is a channel in the neurons which mediate the entry of chloride ions. And over this channel, there is presence of a receptor called as GABA A receptor. GABA A receptor. So how GABA work is, whenever GABA comes in the brain, it stimulates this receptor, GABA A receptor. And whenever it binds to GABA A, it will open the channel. And when channel opens, chloride enters. And we know chloride is a negatively charged ion. So when negative charge enter inside the cell, the membrane potential will start becoming negative. Okay? So it become from -70, it become -80, -90, -100. So more than normal negative resting membrane potential is called as hyperpolarization. So the neurons get hyperpolarized. That means they cannot be stimulated. So brain get depressed. Is it okay? So very simple mechanism. GABA binds, channel opens, chloride enters, brain depresses. Okay. Now special thing to remember, over this channel, chloride channel, not only GABA but some other receptors are also present. Like this also contain a receptor for benzodiazepines, and it also contain receptors for barbiturates. So what happens when we give barbiturates? They bind to their receptor. So just like GABA, barbiturate also bind to their receptor, and they will also open the channel, and that will lead to entry of chloride and brain can be depressed. So barbiturates are also CNS depressants. But on the other hand, when we give benzodiazepines, benzodiazepine bind to their receptor, but channel do not open. Benzodiazepine bind, channel do not open. But what happens when benzodiazepine bind? Now the binding of GABA to its GABA A receptor increases. So that means more GABA can bind to GABA A receptors, and when GABA A is stimulated, the channel opens and chloride is entering. That lead to depression of brain. So basic difference is barbiturates themselves open the channel, but benzodiazepines help GABA to open the channel. Is it okay? So we discuss the difference between barbiturates and benzodiazepines. Barbiturates and benzodiazepines. Barbiturates themselves open the channel, so they are called as GABA mimetic. They mimic the action of GABA. Just like GABA, they open the channel. But on the other hand, benzodiazepines are called as GABA facilitatory. Facilitatory, as the name says, they will facilitate or help GABA to open the channels, but they themselves will not open the channel. Okay? So basically what happens, benzodiazepines will go and sit on the chair there and they start ordering, chalo chalo, channel kholo, channel kholo, channel kholo. Okay? So they help GABA to open the channel, they themselves do not open the channel. Okay, so this is the major difference between barbiturate and benzodiazepine mechanism. But second important difference is both barbiturate and benzodiazepine help in opening the chloride channels. The difference is barbiturate increase the duration of channel opening, whereas benzodiazepines increase the frequency of channel opening. What is the meaning of this term is, hypothetically assuming, suppose this chloride channel opens 5 times every minute in a normal person. Suppose in a normal brain, this chloride channel opens 5 times every minute, and every time it remain open for 2 milliseconds, hypothetically we have assumed. So that means in 1 minute, this channel is open for 10 milliseconds in a normal person. When we give barbiturate to this person, barbiturates, they increase the duration of channel opening. That means the channel will open same 5 times. Number will be same. But every time it will remain open for longer period. So instead of 2, it may remain open for 4 seconds. So the total time for which this channel is open is 20 milliseconds. So more chloride has entered, and that can lead to depression of brain. Okay, but on the other hand, when we give benzodiazepines, this channel opens for same time, that means 2 milliseconds, but instead of 5, this will open 10 times every time for 2 milliseconds. So the final effect will remain same, that means the channel is open for 20 milliseconds. So both barbiturate and benzodiazepine lead to more entry of chloride in the brain, and that will lead to depression of brain. But the difference is, barbiturates are GABA mimetic, and they increase duration of channel opening, whereas benzodiazepines are GABA facilitatory, they increase the frequency of channel opening. Now what the question is, why this happens? Why benzodiazepine increase frequency, not duration? So you can very easily assume benzodiazepines do not work themselves. So what they do? They bind to the benzodiazepine receptor, channel do not open. Okay? So they will sit there. Now their function is to order, chalo open karo channel. So who will open the channel? It is the GABA which will open the channel. So GABA opens the channel for 2 milliseconds, so it will open for 2 milliseconds only. So but important thing is, they are constantly ordering, do the work, do the work, do the work. So again and again GABA will keep on binding. So when it binds more number of times, so the frequency will open. Okay. On the other hand, barbiturate, they themselves work and they bind for a longer period, so they open for longer time. Is it clear? So the major differences between barbiturates and benzodiazepines: barbiturates are GABA mimetic, benzodiazepine facilitatory. Barbiturate increase the duration of channel opening, benzodiazepine increase the frequency of channel opening. Okay. Then third important difference, which we discussed earlier in general pharmacology, barbiturates have steep dose response curve, whereas benzodiazepines have flat DRC. If you remember, when we discussed in general pharmacology regarding the dose response curve, barbiturates have this type, barbiturates, whereas benzodiazepines have this type, flat DRC. And do you remember what is the difference in the DRC? Due to slope? Yes, S for slope, S for safety. Slope tells about safety. Barbiturates have steep DRC, that means with slight increase in dose, response increase so much. So barbiturates are relatively unsafe drugs, whereas benzodiazepines are much more safer. So commonly for sedative hypnotic function, we prefer benzodiazepines, not barbiturates. Okay, so barbiturates are unsafe, benzodiazepines are relatively safer drugs. Next important difference is, barbiturates are very strong enzyme inducers. Barbiturate induce the enzymes, whereas benzodiazepines do not. So barbiturates are strong enzyme inducers, so that can lead to lot of drug interactions. They increase the metabolism of many drugs, they may become ineffective. Then barbiturates induce the normal enzymes also, normal physiological enzymes also. Like barbiturates can induce an enzyme called as delta amino levulinic acid synthetase. This is the rate limiting enzyme in formation of porphyrins. So when we give barbiturate, this enzyme is induced, so more porphyrins can be synthesized. And if a person is already having more porphyrins, that way the problem will aggravate. And which is that disease known as? Yes, acute intermittent porphyria. So barbiturates, they are contraindicated in patients with acute intermittent porphyria, whereas benzodiazepines can be used. Okay, next, barbiturates, they are highly addictive. Both barbiturates and benzodiazepines have addictive potential. but barbiturates are highly addictive. Benzodiazepines are also addictive, but they are less addictive than barbiturates. Both are addictive. Okay. Next very important difference is amnesia. Both barbiturates and benzodiazepines, they can produce amnesia. Amnesia means loss of memory. Now there are two types of loss of memory. One is known as anterograde amnesia. Second is known as retrograde amnesia. Retrograde amnesia, as you see in movies, the person do not remember anything. मैं कौन हूँ, कहाँ से आया हूँ, nothing is known. But on the other hand, these drugs cause anterograde amnesia, not retrograde. Anterograde amnesia means after taking the drug, what happens, the person forgets. Past memory is present. So both barbiturate and benzodiazepines cause anterograde amnesia, and barbiturate cause more and benzodiazepine less. Both cause amnesia, barbiturate more likely to cause. Okay. Then lastly, if the overdose occur, if the toxicity occur, we have no antidote for barbiturates. We have no antidote. Only symptomatic treatment, plus because barbituric acid derivatives, so we can alkalinize the urine to help in their excretion, but we have no specific antidote for barbiturates. On the other hand, benzodiazepines have specific antidote, so managing the poisoning is relatively easier, and the specific antidote for benzodiazepines is flumazenil. Flumazenil, it is benzodiazepine antidote. Flumazenil is antidote for benzodiazepine, and from the name you can remember benzodiazepine. The name end with peen. पीने से मजे आते. So this is a drug जो मजे को नील कर देगी. मजे को नील कर देने वाली दवाई फ्लूमजेनिल. बेंजोडाइजेपिन का एंटीडोट है मजेनिल, फ्लूमजेनिल. Clear? So if you see the differences between barbiturates and benzodiazepine, apart from the first two differences which are related to mechanism, rest all are disadvantages of barbiturates. Barbiturates have steep DRC, means they are unsafe drugs. Benzodiazepines are relatively safer. Barbiturate are strong enzyme inducers. They are causing lot of drug interactions, plus they are contraindicated in AIP, acute intermittent porphyria. Benzodiazepines are safer. Barbiturates are more addictive than benzodiazepines. Barbiturate have more amnesia causing potential than benzodiazepines, and barbiturate do not have any antidote, whereas benzodiazepines have antidote. Okay. So because benzodiazepine have all the advantages and barbiturates have all the disadvantages, so currently we mainly use benzodiazepines. For sedative hypnotic purpose, we do not prefer barbiturate, we mainly use benzodiazepines. So in fact, barbiturates are very less often used these days. Very few barbiturates are used nowadays. Initially we have around 10-12 barbiturates, but currently only 2 barbiturates are used in clinical practice. So first we'll talk about these, then we will talk about benzodiazepines. Okay, so only 2 barbiturates are currently being used. One is thiopentone and second is phenobarbital. Thiopentone and phenobarbital. Thiopentone is used in anesthesia. We will discuss in detail when we will discuss anesthesia. And phenobarbital is used in epilepsy. We will discuss it along with other anti-epileptic drugs. Okay, so that is important to remember about barbiturates. But now coming to more important drugs, which are benzodiazepines. Benzodiazepines, we have diazepam, nitrazepam, flurazepam, flunitrazepam. These are some examples of benzodiazepines. So we discussed benzodiazepines are preferred over barbiturates. But if you remember, earlier we discussed diazepam, it is metabolized to form oxazepam. What is the special property of oxazepam? Yes, this is the active metabolite. So that means oxazepam also depress the brain. So if we give diazepam and hypothetically assuming, suppose it works for 6 hours and oxazepam also works for 6 hours. So we have given diazepam at night for producing sleep, and we thought that it will work for 6 hours. So person will take diazepam at night and the person will wake up in the morning. But this does not happen, because after some time oxazepam will be produced. It will keep on depressing the brain for another 6 hours. So that means person will not wake up in the morning. Person will keep on sleeping till afternoon. Okay? So that is the problem with the most of the benzodiazepines. They are very long acting. And the reason of the long action is they produce active metabolites. So most benzodiazepine produce active metabolite. So they are very long acting. Very long acting. This is the one problem. Second problem is, because they are long acting, the person's brain will contain diazepam or oxazepam or its metabolite for long period. Now, if the person wakes up in the morning, what will happen? The person will keep on zooming till afternoon. Okay? So the person will feel sleepy and the person will have headache and some other problems till the afternoon, till the time benzodiazepines are present in the brain. So that is known as hangover. So the problem is same. Due to long duration of action, these are associated with hangover. Third important thing, benzodiazepines are CNS depressants, and people, particularly elderly, they are very sensitive to CNS depressant drugs. And if a drug depresses the brain for very long period, then we will not like to use, because the drug is, person is sensitive and the drug is depressing the brain for long period. So we will not like to use the drug. So due to this reason, these are avoided in elderly. But the major problem is, insomnia is mainly a problem of elderly, and the very age group where we want to use these drugs, these are avoided. So benzodiazepines cannot be given in elderly. Next, these are metabolized to form active metabolite. So that means if there is liver failure, they will not be metabolized. So they will accumulate, and when they accumulate, that will lead to toxicity further. So these are contraindicated in liver failure. So we discussed 4 problems of benzodiazepines, all 4 resulting from same reason. They are producing active metabolites. They produce active metabolites, so they become long acting. They are long acting, so they can cause hangover. Plus they are long acting, so they are avoided in elderly, and plus they are metabolized, so they are avoided in liver failure. Okay? So the problem is same for all 5 problems. The root cause is same. So if we want to avoid these 5 problems, the solution, simplest solution will be, we will want such a benzodiazepine which do not form active metabolite. If there is no active metabolite, it will be short acting, and if it is short acting, these problems will be solved. So what are those short acting benzodiazepines? So you can remember the short acting benzodiazepines as stool drugs. Short acting benzodiazepines. S for short acting benzodiazepines. These include, for T we have 2, temazepam, triazolam. Then we have oxazepam, lorazepam, and estazolam. So temazepam, triazolam, oxazepam, lorazepam, estazolam. These are short acting benzodiazepines. And why they are short acting? Because they do not produce active metabolite. So you can remember 5 important MCQs by remembering this mnemonic. So 5 important MCQs will be, number 1, which of the following is a short acting benzodiazepine? The answer will be stall drugs. But be very careful, the shortest acting benzodiazepine is not in this group, because that shortest acting benzodiazepine is mainly used in case of epilepsy, in seizures. So that is midazolam. So overall shortest acting benzodiazepine is midazolam. It is used for seizures and for anesthesia. So midazolam is not used for insomnia. So midazolam is shortest acting benzodiazepine overall, but these are the other short acting benzodiazepines. They do not produce active metabolite. So second question, which benzodiazepine do not produce active metabolite? Answer is one of the stool drugs. Then third, which has less chance of causing hangover? Again stool drugs, because they are short acting. Fourth, which is safe in elderly? Again stool drugs, because they are short acting. And which are safe in liver failure? Again stool drugs, because they are not forming the metabolite, or they are basically not directly metabolized by liver. Clear? So these stool drugs are very important to remember. They will answer most of your MCQs regarding benzodiazepines. Clear? Now coming to one important point. Benzodiazepines, they induce sleep. They are used for insomnia. So first of all, we'll talk a little bit about the sleep. Sleep, we all know, have two phases, REM and non-REM. Non-REM has further phases, phase 1, 2, 3, 4. Different phases are there. Now first question, in which sleep dreams come, REM or non-REM? Very good. Dreams come in both the sleeps. The dreams which come in REM sleep, they can be remembered. Which come in non-REM cannot be remembered. So from the name you can remember REM, it is remembered. Whereas non-REM not remembered. Now coming to our main point, these different phases of the sleep, they have some fixed duration. So hypothetically assuming, suppose REM phase lasts for 20 minutes, phase 1 sleep, it lasts for 10 minutes, phase 2 for 20 minutes, phase 3 for 10 minutes, phase 4 for 10 minutes. Hypothetically assuming I have written anything. Not important. This is not the right values also. After phase 4, again the REM sleep will come. 20 minutes, then phase 1 10, phase 2 20, and so this will keep on changing, keep on repeating again and again. So when the sleep comes in this quality, it is called a good quality sleep. That means if a person sleep for 6 hours, when the person wakes up, the person will feel refreshed. This is a good quality sleep. Okay. Now when we give barbiturate or benzodiazepines, they increase sleep duration. They increase sleep duration. But the problem is they do not increase all the phases proportionately. Some phase will be increased more, some will be increased less. Like after giving barbiturate or benzodiazepines, mostly we use benzodiazepines nowadays. Suppose the sleep duration now become, this is for 25 minutes, this is for 12 minutes, this is for 30 minutes, this is for 8 minutes, this is for 6 minutes, hypothetically assuming. So benzodiazepines, they have increased the duration of sleep, but all the phases are not increased proportionately. Some phase increased more, some less, or some may even be decreased. So that means when we give benzodiazepine, the sleep quality no longer remain normal. So that means although they increase the quantity of sleep, but they compromise the quality of sleep. And technically that word is known as, they cause distortion of sleep architecture. They cause distortion of sleep architecture. In simple language, in Hindi you can say ghatiya quality ki sleep. They compromise the quality of sleep, means person will sleep for 8 hours instead of 6 hours, but after waking up person will not feel refreshed. Person will feel that I have not slept enough. Yeah. So barbiturate and benzodiazepines, they increase the quantity of sleep, but they compromise the quality of sleep. Clear? Now next thing to remember, what is the basic problem in insomnia? What is the basic problem? In insomnia, नींद नहीं आती. Person is not able to sleep. Saturday राती नहीं, कभी भी नींद नहीं आती. So what happens, suppose this is the time at which person try to sleep normally. Suppose this is the 11 p.m. time. Person normally try to sleep at 11 p.m. A normal person, he will fall asleep in 10, 15, 20 minutes. So person has tried to sleep at 10 p.m. and at 11 p.m. at 11:15 p.m. person sleeps. So this is the normal time. 10, 15, 20 minutes the person will fall asleep. This time is known as latency of sleep onset. Latency of sleep onset, or in simple words, after how much time after starting or after trying to sleep, the person sleeps. In a normal person, this is around 10, 15, 20 minutes. But a person with insomnia also try to sleep at 11 p.m. but the person is not able to sleep. It is 12 p.m., 1 a.m., 2, 3, 4 a.m. So person is sleeping at 4 a.m. So this is the latent period now. So that is the major problem in insomnia. Person is not able to sleep even after trying. So latent period increases. When we give barbiturate or benzodiazepines, they decrease the latent period. That means person will try to sleep at 11, person will sleep at 11:30, 11:40. They will decrease the latent period. Instead of 4-5 hours, person will sleep in half an hour. But the problem is, although they decrease the latent period which we want, they cause distortion of sleep architecture. They have reduced the time in which person sleeps, but they cause decrease in quality of sleep also. They compromise the quality. They increase the quantity but decrease the quality of sleep onset. So that is the major problem with benzodiazepines and barbiturates. So we want a drug which reduce the latency of sleep onset without affecting the quality. Even if they do not increase the quantity, we are okay, but they decrease they should not compromise the quality. So in search of such a drug, we came to a group of drugs called as non-benzodiazepine hypnotics. Non-benzodiazepines hypnotics, in my language I say these are jet drugs because the name of most of them start from jet. So these drugs include zolpidem, zaleplon, zopiclone. All are starting from jet, but recently an isomer of zopiclone has also been approved, which is called as S-zopiclone. All these are non-benzodiazepine hypnotics. The major advantage of these drugs are they decrease the latency of sleep onset which we want, but they do not affect the quality. They do not compromise the quality because they do not do anything. They do not do any change to any of the phases of sleep. That means REM, phase 1, phase 2, phase 3, phase 4, they remain same. They do not increase the duration. They only decrease the latency. So they decrease latency without compromising the quality. And further, they are not increasing the sleep quantity also. Person will sleep for 6 hours only, but only person will fall asleep earlier. Because they do not increase the quantity, which side effect will not be there? Yes, there will be no risk of hangover. So they do not cause hangover also. So they decrease the latency without compromising the quality or causing hangover. In addition, they are non-addictive also. They are not addictive. So because of all these properties, decrease in latency without compromising the quality, no risk of hangover, no risk of addiction, these are now become the drug of choice for insomnia. So jet drugs are now the drug of choice for insomnia. Okay, and these jet drugs, they act by stimulating the benzodiazepine receptor only. But they do not stimulate all types of benzodiazepine receptors. They only stimulate omega subtype of benzodiazepine receptors. So in some books it is called omega, some books it is called as alpha subunits of benzodiazepine receptors. Omega 1 basically, omega 1 or alpha 1 subtypes of benzodiazepine receptors. They do not affect the omega 2 subtype of benzodiazepine receptor, only omega 1 subtype. So advantage of this is they only decrease the latency of sleep onset without affecting the quality. In addition, benzodiazepines like diazepam, they have several other uses also. Benzodiazepine is not used for only insomnia, but benzodiazepines are also used for anti-anxiety purpose. Benzodiazepines are also used for we can say muscle relaxant purpose. Benzodiazepines are also used as anti-epileptic drugs. But jet drugs or zolpidem like drugs, they do not possess any other quality. They have only one use, that is insomnia. They do not possess anti-anxiety property. They cannot relax muscles. They have no anti-epileptic properties. So only use is they are used for decreasing the onset of latency of onset of sleep. That means for insomnia. Clear? But because they are binding to benzodiazepine receptor only, so their antidote is also flumazenil. So flumazenil will not only antagonize benzodiazepine but also jet drugs. Okay. Then coming to one more point, normally we sleep at night and we are awake during the day. So what is the sensor present in the body which determine this day-night cycle? That we should sleep at night, we should be wake up at morning. Which is that clock? Which is that day-night cycle, or we can say which is that sensor present? That is known as, yes, it is melatonin. So melatonin, it is secreted when there is dark, and that will induce sleep. So melatonin will induce sleep. So when melatonin is inducing sleep, then we thought that when we want to change the day-night cycle, we sleep at night, we are awake during the day. But suppose a person who has night duties, person cannot sleep at night. So we want that melatonin should not be secreted at that time. It should not work. Melatonin should be secreted during the day so that the person sleeps during the day. Another thing is jet lag phenomena. The person has gone from one country to another country where day-night time is different. So we want the person to adjust to this new schedule. Clear? So in these cases, melatonin can work. And the conditions are called as shift workers. The first condition, where shifting working hour duties there. And second, jet lag phenomenon. In these conditions, we want to stimulate the melatonin receptors when we want the person to sleep. So we have developed a drug called as melatonin receptor agonist. If we stimulate the melatonin receptors, person will sleep when we want. So person can adjust to new schedule. And that melatonin receptor agonist is Ramelteon. So from the name itself you can remember, Ramelteon says it is melatonin. Melt means melatonin, receptor agonist. Melatonin receptor agonist is Ramelteon, or you can safely remember MELT is melatonin is on. So it will make melatonin on. Melatonin काम करना शुरू कर देगा. So it is indicated in shift workers and jet lag phenomena. But recently it is found that when melatonin is inducing sleep, so we can use Ramelteon simply as sedative hypnotic also, simply to induce sleep for insomnia. Why only in jet lag? So it is now approved for insomnia also. Okay, so it can be used for shift workers, jet lag, as well as for insomnia in other people. Now special points about Ramelteon to remember. Ramelteon also decrease latency without compromising the quality or quantity. Number one. Second, it is also non-addictive like non-benzodiazepines. Now special thing about Ramelteon, it has very poor oral bioavailability. Oral bioavailability of Ramelteon is very low, less than 2%. But because the conditions like shift workers or the condition like insomnia, no person will want injectable drug. So still it is given orally but in very high doses because bioavailability is lower. Then it can cause psychiatric side effects in some people. The major problem is psychiatric adverse effects can be noted in some people. And it is also metabolized by microsomal enzymes. So it can show drug interactions. We should be careful which other drug person is taking because enzyme inducers will increase its metabolism and inhibitors will decrease its metabolism. So that is important about melatonin agonist Ramelteon. Okay. Then the last thing, in the brain there are presence of orexin receptors. Orexin receptors, they promote wakefulness. That means whenever they are stimulated, person is awake. So then we thought that if we block these receptors, if we antagonize these receptors, the person should sleep. So on the basis of this, we developed the drugs which are orexin receptor antagonists. So when we give antagonist, they will produce sedation. So they can be used for insomnia. So one drug which is approved since few years now, it is suvorexant. And recently another drug is approved for same purpose. It is lamborexant. They are used for insomnia, and from the name you can remember the name of these drugs ends with orex ant. The name end with orex ant means they are orexin antagonist. Orex ant means antagonist. So these are orexin receptor antagonists, and they can be used in insomnia. And the first drug from the name you can remember, name start with S, means they are used to induce sleep. They are used for insomnia. Okay.